Before we get started in this episode, a quick announcement. As you know, I'm very passionate about acceptance and commitment therapy, and I also run a busy practice in Canberra. We're currently looking for psychologists who are registered in Australia to join our team, who are also passionate about learning about ACT. We provide supervision on a group and individual basis and training around ACT. So if this is you, if you're interested, please express your interest at strategicpsychology.com.au/careers. Look forward to hearing from you. And now back to this episode.
Okay, life can be crazy. You're feeling like you're sinking, just trying to find a meaning. It's time for better thinking. Yeah, better thinking. Time to tune in. Let's go.
Welcome back to Better Thinking. My name's Nesh Nikolic, and my guest today is Dr. Fiona Kumfor, here to talk to us about social cognition in clinical syndromes with a focus on dementia. By better understanding dementia and other neurodegenerative diseases, her research aims to improve diagnosis and prognosis of the disease. Dr. Fiona Kumfor holds a Masters in Clinical Neuropsychology from Macquarie University and a PhD in Neuroscience from University of New South Wales. She is currently an NHMRC Career Development Fellow, Associate Professor in the School of Psychology, and registered clinical neuropsychologist with AHPRA. Combining her clinical training in neuropsychology and research expertise in cognitive neuroscience, her work investigates social cognition in clinical syndromes and aims to really understand the diagnosis and prognosis aspects of dementia to remove stigma, understand how to better provide interventions, and inform neurobiological models for these complex behaviours. I found this conversation exceptionally interesting and was quite optimistic towards the end, in that there are lots of things to be hopeful for, in particular some of the research findings that Fiona's team has looked at and others around the world. And I think it's something that we can all be optimistic about in the aging process. So hopefully you enjoy this as much as I did. Fiona, a big thank you for coming onto the show today.
Thank you for having me.
I like to start a lot of my interviews with the question of, what got you into this space, and sort of the world of, neurodegenerative, diseases and dementia and Alzheimer's and the like is fairly unique in psychology, even though it's very prevalent. But maybe we can kind of start there. How did you get into this space?
Yeah, so I did my undergraduate degree in psychology and my honours in psychology as well, and then decided to go and study my Masters of Neuropsychology. And that was really out of an interest of, trying to understand brain behaviour relationships, but also a real interest in the various different clinical syndromes. So in undergraduate, we had heard about some of those classic examples in psychology, like HM, who had sort of bilateral temporal lobectomies and the impact on memory. And I just found it really fascinating, these sort of case examples. And then when I was doing my Masters of Clinical Neuropsychology, as part of that program, you do placements in various areas and different hospitals. And I was doing a placement in the geriatrics ward. And we were asked to see a man who I still remember very, very clearly, who had been brought in by nuns because he was found wandering the streets, and at home he'd been hoarding and was really having difficulties looking after himself. And then when we were asked to do the neuropsychological assessment, I started doing an interview with him and found out that he had this really fascinating background. He'd done a Bachelor of Arts. He was very, very, very highly educated, very well read, presented, he was able to have a great conversation. And then when we started doing testing, he actually did really well on testing as well. So there was this real disconnect between, his cognitive performance on things like, his vocabulary, his general knowledge, and how he was behaving in everyday life. And I found that really striking. It was very different from what we'd sort of been taught in neuropsychology. And around that same time, I was actually very lucky to hear a talk by Professor John Hodges, and he's quite a well-known neurologist. And he was talking about this syndrome of frontotemporal dementia and talking about how this dementia syndrome, unlike other dementia syndromes, presents as changes in behavior and personality. And he really opened my eyes in terms of this whole area of research that I had very little knowledge about in terms of these atypical dementia syndromes. And ultimately, the person who I'd seen clinically got a diagnosis of frontotemporal dementia. So actually, based on that one person that I saw clinically and that talk that I saw, I then went on to do a PhD in the area and sort of pursued John Hodges to be my supervisor and to go on and research that area. And I've actually stayed researching frontotemporal dementia ever since, because I just find it absolutely fascinating, this whole area in terms of, where things can go awry in the brain and how that has such an impact on someone's behavior and personality and really their ability to function in everyday life.
Wow, it's quite an inspiring thing to see the difference of what you would what you're kind of expecting to see from all the literature versus seeing something that's a bit atypical and going, oh, wow, that's fascinating. Why is that coming up? Because you would usually see that if someone's behaviors are a bit disheveled, for lack of a better word, that they're probably, their mind is going to be a little bit disheveled as well in terms of organizing and the like. But someone who's able to be quite coherent and in actual fact, quite intact in terms of how they think and the like is neuro, they kind of, in many ways, it's neurotypical compared to what you're seeing on the outside. So fascinating. What are the typical versus atypical signs that you would, commonly see? And obviously every presentation is different, but what would you say would be that the typical things that, one would observe in whether it's dementia or other degenerative, diseases?
Mm-hmm. So I like to think of dementia, it's an umbrella term, and probably the best way to explain that to people is the same way as cancer is an umbrella term. And within that, we have many different subtypes. So you might have melanoma, breast cancer, leukemia, so forth. Dementia is very similar in that it's an umbrella term, and within that, there's different subtypes. So probably the most common form of dementia that people would have heard of is Alzheimer's disease. And even though people might use those terms interchangeably, they're really not the same. So Alzheimer's disease is a subtype of dementia. And Alzheimer's disease usually affects older adults. So one of the biggest risk factors is age. And again, when people think about Alzheimer's disease, it would usually present as someone having memory problems, and in particular, the ability to learn and encode new information. So, for example, someone with Alzheimer's disease might not remember what they had for breakfast this morning. If you met them briefly, they might not remember, meeting you recently. And they can also have challenges in terms of navigation, so they might get lost. They may have some word finding difficulties, but that's sort of the typical profile of Alzheimer's disease. And then as the disease progresses and there's more pathology in the brain, so more of these abnormal protein depositions that are accumulating in the brain, then more areas of the brain will get affected and more symptoms will emerge. But really in that early stage of the disease, it's predominantly episodic memory that's impaired. If we think about going back to that umbrella term of dementia, there's actually over 100 different subtypes of dementia. So it's really heterogeneous. There's multiple reasons. And, the different subtypes are defined by the different types of pathology that is depositing in the brain. So, for example, some of the other common subtypes of dementia is vascular dementia. And that's related to where there's changes in the brain in terms of the blood flow, which then can lead to specific parts of the brain being affected. Typically in vascular dementia, you will see changes in people's speed of processing. So they might be slower in terms of how they do things. And they might also show changes in executive functioning. So that sort of higher level thinking. Other forms of sort of common dementia syndromes is dementia with Lewy bodies. And, dementia with Lewy bodies is characterized by this deposition of Lewy bodies in the brain. And in terms of the presentation there, people can actually show hallucinations is one of the more common features, and they can also show memory problems. So there's multiple different subtypes, and they all have their own different clinical presentation. In people who, often in dementia, we will think about as another subgroup of younger onset dementias. And that is people who first get the clinical symptoms of dementia before the age of 65. And in this younger onset dementia subgroup, while Alzheimer's disease still happens, actually frontotemporal dementia is just as common. And so it's much more prevalent in people in their 50s and 60s. And it presents as changes in behaviour as well as changes in language.
And so to help me understand this, the umbrella term of dementia in many ways still looks at some type of neurodegeneration, but some of that might be vascular, for example, might be related to the vascular side, which changes the blood flow and therefore might impede how the brain works and potentially degenerate over time because of blood flow reasons, or there's some sort of interrelation there. But it could be things like you mentioned Lewy bodies. I'm not really sure what Lewy bodies are, but I'm assuming it's some type of compound that collects over time, or some sort of chemical. What is that what we're talking about? But it's still related to some type of neurodegeneration, or that the brain is not functioning in its typical form.
Yeah. Yes, so there is quite a bit of terminology in this area.
Yeah, please help me.
It is tricky. So clinically, that when we're diagnosing dementia, there's two different criteria that needs to be met. The first is that someone needs to have a decline in function or a decline in cognitive ability from how they were previously. So that could be across a variety of different cognitive domains like memory, but also language, executive functioning, visuospatial ability, behavior, and so forth. So they have to show a decline. So if, for example, someone had a developmental delay where they'd always had difficulties in memory, for example, or language, they wouldn't meet criteria for dementia because it's always been there. So you need to be able to show a decline. And it also has to impact on an individual's functioning. So even if someone does poorly on a memory test, that doesn't necessarily mean they have dementia. It needs to impact on their everyday functioning. So, for example, their ability to work, their ability to do things in everyday life, whether that's cook or clean or pay their bills, and so forth. So that is what we talk about the term dementia, is that sort of decline from previous functioning.
Mm-hmm.
In terms of why that occurs, that's when we start to think about neurodegeneration. So it's really the reason causing this clinical syndrome. And the neurodegeneration in the brain, as you said, can occur for a number of different reasons. And that's why we have all of these different subtypes. So yes, it's possible that you could get neurodegeneration because of vascular changes where blood supply is affected in the brain, or you will see abnormal proteins in the brain. So, for example, in Alzheimer's disease, we know that the proteins are amyloid plaques and tau tangles, so neurofibrillary tangles. And they're proteins that in people with Alzheimer's disease are seen in abnormally high levels. So they're accumulating in the person's brain. And when you have a lot of this protein accumulating over time, that causes the cells in your brain to die. And that will lead to atrophy or shrinkage of particular areas of the brain, which will then cause the clinical symptoms in terms of the cognitive changes. Does that make sense?
Yeah, absolutely. Absolutely. Just to clarify a little bit more, in terms of the decline from previous functioning, is that similar to how we might look at it in sort of, regular diagnostics in psychology, where usually the function there has to be that kind of impairment in social or occupational. It needs to kind of meet a functional problem rather than, maybe it's subclinical because it's not causing, a functional problem. Is that similar in nature or a diagnosis?
Yeah. So it's very similar. Yes, in dementia, you need to have an impact exactly on someone's occupational or social functioning to be considered having a diagnosis of dementia. We do also recognize the sort of intermediate stage, which you might have heard of, which is called mild cognitive impairment.
Mm-hmm.
And that might be where people start to have some concerns around, for example, their memory or some subtle cognitive decline. But they're still managing to cope with it. They might have sort of compensatory strategies in place. They may still be able to work, but they have some concerns. For some people with mild cognitive impairment, they will go on to develop dementia, but not for everybody. And so there's a lot of work being done internationally when we're thinking about, for example, developing drugs to target these different dementia syndromes, because often these drugs may work best in those very early stages. So it's unlikely that a drug is going to be developed that will be able to regrow neurons and regrow that the brain areas that have been damaged. What's more likely is that the drugs will try and stop that pathology or those proteins in the brain from accumulating. And so the best way to do that is to identify people as early as possible. So that's why, in addition to the sort of dementia diagnosis, where it does have that impact on functioning, we'll also recognize a sort of mild cognitive impairment where there's sort of early signs that something might be happening, but it's not yet impacting on someone's occupation or social functioning.
And what's the current research in terms of the most likely contributors to this? And I know it's a large, and complex, and probably doesn't have a specific answer, but at least what's our best understanding? Obviously we do appreciate, or I believe, and please correct me here, but it is very much an older person's disease, so to speak, that, it's rare. I'm sure there are cases, but it's rare for it to occur, in someone's 30s. So we kind of see this in the older age, and in many ways, it's fairly common. I'm assuming in those later years, and early is considered, before 65. But what are the contributors? I'm sure if I did a Google search, I'd hear lots of strange ideas coming forward, like, eating too much sugar or this or that. Is there a best guess at the moment? What are we looking at that is at least correlated, or have a reasonable correlation to why people are developing dementia? Or is that just what happens when things start to decay? Like heart disease in many ways. Yes, we probably shouldn't eat all the rubbish that we eat and so on and so forth, but I think it does decay over time, right? And you do kind of get heart disease. You've got to get disease somewhere, right? And the heart is one place and the brain is probably another place. So what's the current consensus, or at least hypotheses?
Yes, so it's a very big question. So the first thing to say is that dementia is complex. So if you think about like COVID-19, for example, is, that's quite a good example where there's been very, very rapid development in terms of understanding the disease, developing vaccinations, developing potential, treatments, and we've got a lot of understanding on COVID. That's quite different to something like dementia, where it's not going to be a single thing. It's not going to be one virus that causes it. So there's going to be multiple factors that are leading to whether a person gets dementia or not. The first thing that we can think about is genetics. Are there genetic risk factors? Certainly, there is a subgroup of people who get dementia because they have a genetic mutation, and that could be an autosomal dominant mutation, which means that if one of your parents has the gene, you've got a 50-50 chance of inheriting it. So those genetic causes of dementia are relatively uncommon. And if people have an autosomal dominant, genetic mutation in their family, it's usually fairly obvious in someone's, if you look at your family tree. So you'll be able to clearly see across generations that people have been affected. So again, similar to other disorders like the breast cancer gene, the BRCA2 gene, you can see a very clear family history. So there are certainly cases where it is determined by someone's genetics. Then there's a sort of...
And they're quite rare, and it's fairly obvious that this gene is in this person, and therefore they have a very high possibility of developing, because it just tends to, once it's triggered, so to speak, it tends to express itself that way, and you can see that in a linear sort of way across offspring and the like. But that's quite a small subgroup. That they're the easy ones to kind of point the finger at.
Yes, exactly. Then there are also genetic risk factors, where if you look at the population, there's certain forms of genes that might increase your risk. And again, probably the one that we know the most about is the APOE gene. And this gene, there's 3 different versions of it, or alleles of it. If you have APOE2, it's actually protective. It means that you have a lower risk of developing Alzheimer's than in the population. If you have APOE3, it's sort of, the neutral version. It doesn't make you particularly at a higher risk or a lower risk. And if you have APOE4, it actually increases your risk by about 10 times compared to the rest of the population. So it doesn't definitely mean you're going to get it, but you have a higher risk than other people. And people might have heard of this. What's his name? Chris Hems has just been revealed that he has this APOE4 version of this gene. So it doesn't mean he is definitely going to get it, but it increases his risk. So, that is a potentially contributing factor for Alzheimer's disease, is those sort of genetic side of things. In terms of
my apologies, yeah. If someone has that APOE4, for example, are there any... is there anything that is likely to methylate or to trigger APOE4 to then express itself in a dementia form? Are there certain things that are more likely? Obviously, I'm assuming this has to be huge sample sizes, and you're trying to control for all sorts of things. So it's almost impossible. But is there any understanding in terms of what are those things on the APOE4 scenario?
So with everyone, our genetics interact with our environment. And there's a number of modifiable risk factors that have now been identified. So if someone has that APOE4 variant, then they have the opportunity to change some of these modifiable risk factors that then may lower their risk. So there was a really good review put out by The Lancet a couple of years ago that looked at all of the studies in dementia to look at all of the modifiable risk factors. Quite a few of them probably aren't surprising, because really what is good for your brain is good for the rest of your body. So that's things like eating a Mediterranean diet, exercising, staying fit and healthy. There were other sort of more unexpected modifiable factors that have really gained a lot of interest now in terms of follow-up. So one of those, for example, was hearing impairment. And one of the things that they found was that potentially if someone has a hearing impairment and that's treated, so for example, if someone's given hearing aids, that seems to minimize their risk of dementia. So that's a possible area where, if there are people who have concerns around hearing impairment, that's a really good reason to go and get that investigated and see if there's hearing aids that are suitable, because that can modify your risk.
Wow.
One of the, yeah.
That is, I can see some connection. Like, if I put a narrative to it, it might be that maybe there's overdiagnosis when it might be explained more by hearing, but where you're talking about improving someone's hearing by hearing aids, maybe there's more stimulation, there's maybe more social interaction, that's more meaningful, that there's maybe more meaningful acts by virtue of being connected with the world. So you're not stagnating as much. Your world is becoming larger. That maybe stimulates more of the brain. I'm just kind of hypothesizing, making these things up, but it sounds like a reasonable narrative to me.
Absolutely, and I think your hypotheses are probably on the right track. So I don't know that there's been a lot of mechanistic studies to see exactly what happens, but two of those points that you raised were actually some of the other modifiable factors that have been identified. So staying cognitively engaged across your lifetime. So we know, for example, people who have a higher education have a lower risk of dementia. So again, thinking about how your brain might actually develop what's called a cognitive reserve, so it's able to sort of deal with some of these pathological changes and compensate for them in some way. So having a high education is a good modifiable risk factor, and really staying cognitively engaged throughout the lifespan. So, whether that be learning another language or, studying, doing an additional degree, anything that you can do to really cognitively challenge yourself seems to be beneficial. And the other aspect that you raised, and what's really particularly of interest to me, is social engagement. So there's been quite a lot of research now showing that social engagement reduces your risk of dementia, and that social isolation could be a potential risk factor. So absolutely, I think it's possible, like you're saying, if someone has a hearing impairment, they may be less likely to participate in social situations, they may withdraw, and then that may potentially increase your risk of developing dementia.
And we move into that social engagement space, and it is a fascinating space, because I do recall watching a documentary where the producers introduce young children into a nursing home environment. And I can't recall exactly whether they checked their cognitive, capacity and the like, but certainly from a mood perspective, in terms of engagement, their energy levels, how vibrant they were, seemed to transform. And I'm only talking from a documentary because they only show you the little bits and pieces that they like, but it was quite, heartwarming and beautiful, and even tear-jerking. But it seemed to me, in particular with having these little people around old people, that something magical was happening. And I know that wasn't necessarily social in the sense of, two peers talking, but it was certainly social in terms of an older person teaching a young person things about life, or a young person walking an old person around to show them something that's of interest. And there's that, beauty in the innocence and teaching and patience and all sorts of beautiful things that were occurring. So I know for me that seemed to spark off a lot of things in my mind, going, oh my goodness, we need to change how we do nursing, nursing homes, and how we look after people. And how do we stimulate mental cognitive growth, across the lifespan, like, even as you're talking about, being cognitively engaged, not only through a formal degree, but for a lifetime, but maybe we can talk about that if that's okay.
Yeah, absolutely. I mean, I think that, we all recognize that human beings are social beings. Even from an evolutionary perspective, we've lived in tribes, we work together. That's really essential to our well-being. And I think, it's really remarkable, this research that's coming out now showing how it has such a huge impact on our health. Even, I was reading a recent study that looked at things like, does being married or being in a relationship change your risk of dementia? One of the things that came out that was really important was actually having a confidant. So someone that you can, really feel comfortable with, seemed to be an important factor in terms of reducing your risk of dementia. So there seems to be so many benefits. And I think absolutely what you're saying in terms of how residential care facilities are currently set up may not maximize that social engagement. So I think, now we're seeing that from not just a social well-being perspective, but actually from a real health perspective, being able to facilitate social participation is really important. And even potentially has the benefits of being able to keep people out of residential care for longer, being able to help people to live in the community, could have not just health benefits, but also economic benefits. And I think it's really important to get that message out, that how important social engagement is. It could be just as important as having a healthy diet and exercising, making sure that we're socially connected. I guess the other reason why I'm really invested in this area of social participation is because it's very closely related to a large area of research that I do looking at social cognition. So if you think about that person I was mentioning right at the beginning, who performed relatively well on our cognitive neuropsychological tests, but seemed to be having a lot of problems in everyday life, we now know that is actually because of this domain of social cognition that's affected, particularly in people with frontotemporal dementia, so that younger onset dementia syndrome that I mentioned earlier. So historically, when neuropsychologists have tested people's cognitive ability, they've really focused on memory, language, attention, visuospatial abilities. So, can someone navigate? Can they draw complex images? And what's called executive functioning. So that's things like decision making and planning and so forth. And they had really neglected this whole area of skills that we use to participate in everyday interactions. So if you think about if you're, having a conversation with someone, you're actually using a whole range of skills. Probably most of them are automatic and rapid without you even thinking about them. So, for example, looking at someone's facial expression, being able to judge how they're feeling. Are they happy? Are they sad? Are they bored? Should you change the topic? Should you keep going down this track? We rely a lot on people's facial expressions, and then we'll update our behavior in response to that. Also, things like nonverbal cues. So thinking about understanding body language, knowing, for example, how close to stand to somebody. That might change depending on if it's a colleague or your partner. So knowing what is socially appropriate, what the social norms are, and how to adjust to those accordingly. Understanding that someone else might have a different perspective to ourselves. So I might love grapes and you might love kiwi fruit. Understanding that we've got different opinions and think about these things in different ways. So there's this whole complex array of skills that support successful social interactions. And what we now know from a lot of research that we've been doing and other groups have been doing internationally is it's really that area of ability that's affected in frontotemporal dementia. And that is the ability that can lead to some of the impacts on everyday functioning and social participation. So even if someone can tell you, exactly who the Prime Minister is, they can, explain what all of these different words mean, they can, process information quickly. If they are poor at understanding how another person is feeling or recognizing another person's emotions, that has a huge impact on their ability to participate in everyday life.
And I imagine it also has a huge impact on their prognosis if they are find themselves isolated, excluded from social events, or unable to engage socially or participate appropriately. It makes it very hard to then have the stimulation to offset some of the challenges that they're having. It's almost like a chicken and an egg. Some of these factors are occurring because of the dementia, but at the same time, also excluding them even more. It separates them or distances them, which is a protective factor. Or distances them from protective factors, and kind of makes them more withdrawn and insular, and maybe adds to how quickly that degeneration occurs. I'm assuming that dementia goes along with depression quite commonly, and that has its own cognitive impacts and social isolation. Am I on the right track there?
Yeah, I mean, it's interesting what you say around depression, because that's quite variable from person to person. Typically, if someone with dementia has good insight into their difficulties that they're having, then that may, be associated with them being depressed and anxious, and they might be concerned about going out into social situations. Actually, what we see in frontotemporal dementia is there's very little insight into the challenges that they're having. So even to the extent where someone might come into our clinic, they've seen their GP, they've had an MRI, they might have seen a neurologist. Lots of people, their family are concerned. They come into our clinic and we say, what's going on? Why are you here today? And they might say, oh, I've had this rash. I'm hoping like you can have a look at my skin. They just have no idea, no concept that, their behavior is problematic, that, there may be some sort of dementia syndrome going on. And that coupled with these social changes can lead to huge burden for families. So what we see.
My apologies for jumping in. Is it that they are unaware and the behavioural changes are quite obvious to others, or they're unaware but the changes are somewhat mild and they can mask it because they still have the capacity, from a memory perspective, but maybe not from a social perspective? Which way are we going in that conversation? Or both, I suppose, both scenarios.
Yeah, so actually often the behaviours can be quite marked. So, for example, even though the changes can happen slowly, where a person declines over a period of time, often they can include things like being socially disinhibited. So, for example, someone might start swearing. They might, behave inappropriately in public. For example, they might, go up and touch or hug or kiss strangers. They might eat off other people's plates, inappropriate in terms of their manners. They may become very apathetic, so they're just not interested in doing things anymore. Sometimes to the point like that person I was talking about earlier, where they may not shower, they may not eat. They can become quite stereotypical in their behaviours, so have specific routines that they want to do every day. So the behaviour changes can really be quite marked and have a considerable impact on their everyday functioning. And for carers, this is obviously quite distressing. But because they don't have very much insight, often it will take quite a long time for them to be diagnosed. So you might see the spouse, taking the person to their GP and saying, look, they're just not the same. They seem really, disinterested in things. They're like more cold. They're doing these strange, inappropriate things. But the GP might do a very simple cognitive test with them and say, look, they're fine. They know what day of the week it is. They know where they are. They can count backwards. They can read things. They're fine. There's nothing going on. So it can be really challenging for family members to deal with, and also for them to get a diagnosis. So the lack of insight is really part of the disease. It's not because the behaviours are mild and they're masking them. They just aren't aware that what they're doing is inappropriate. And if you ask them specifically, they'll say, oh, everyone else thinks I'm mad, but I'm completely fine.
And I imagine it's also very hard for, spouses, loved ones, dependents to walk in to a GP appointment and say, oh, dad has been swearing and he's said these sorts of things, because we don't tend to do it. We try and do it with a bit more social nuance. So it might appear to kind of underreport because, we're trying to maintain, the socially appropriate thing. We don't want to throw the father under the bus in this example. So it must be very hard. And obviously doctors are taught, an infinite number of things, but the one little thing that they might know, whether it's, in mental health or in dementia or, the various other things, is how to do a screening. And the screenings are a bit basic. And what you're saying is it needs to be much more nuanced and comprehensive. And some of that social side needs to be considered in terms of their capacity to read other people's, emotional expressions and this is all obviously if it's uncharacteristic of how they were previous, that's now becoming functionally, a problem, or, where they're able to have good insight into noticing other people's nonverbal cues, and to modify their position, and, even being able to hold someone else's perspective. That empathy starts to potentially waver.
Yeah, exactly. And that's why, I'm always very keen to talk about these other forms of dementia. I think people tend to be getting a bit more aware now in terms of dementia as a syndrome, but still people tend to think of, an older person who might be in a nursing home, doesn't recognise people anymore. But really it's important for people to be aware that there's lots of other ways that dementia can present, like, for example, these behaviour and personality changes, also changes in language. So again, people might have heard of Bruce Willis recently being in the news because of his diagnosis with frontotemporal dementia. And again, that has been really important for those of us working in this field, to be able to highlight that, people can show changes beyond memory. So people may have changes in communication. They may not understand words anymore. They may not be able to pronounce words anymore. Again, that's a possible sign of dementia. And I think that is what is really challenging for families, is they have no idea what's going on. You know, their partner, who's always been loving and caring and appropriate, you know, just has started doing some of these uncharacteristic things, and then they sort of seem to progressively become worse over time. But it's very hard if you don't have the language around that to say, I think they've got dementia. You know, like you said, if you're going to your GP and saying, oh, they just don't seem as interested in things anymore, or, you know, they're swearing a bit more, like it can be very hard to explain that in that sort of medical setting. So one of the things that we're working really hard on is just to raise awareness so that people know that there are these other presentations of dementia. And like you said, if it is uncharacteristic, if it's changing how someone is functioning from how they were before, then, you know, that could be a potential sign and something that's worth following up.
It's a lot easier if someone is disorientated, they've got memory problems, you know, all these quite obvious uncharacteristic things, versus maybe someone that's been difficult to live with, but now they're more difficult to live with. You know, they have kind of been abrupt and a bit challenging at times, but now it's just increasing in frequency, and, you know, they're, you know, less inhibited, and so we it's more of like it's an extension of some of the challenges that we've had previously, but not quite easily verbalized to a GP to say, hey, these are of a concern. And a GP is probably not going to be alarmed by any of those things, or kind of necessarily consider too much beyond that, because, you know, we tend to kind of be triggered by more pronounced expressions or presentations of it.
Yeah, exactly. And I mean, to give you some idea of how, you know, the impact of that. So on average, people with frontotemporal dementia, from, you know, when their family thinks back, when did we start noticing symptoms, to when they get their diagnosis, it's on average around 5 years. So the family are dealing with this for a long time before they actually get a diagnosis. And actually, we suspect there's probably a lot of people out there in the community who never get a diagnosis, whose family might just, you know, fall away. They might think, oh, you know, this is too difficult, I don't know what's going on. They may lose that sort of support network within their family and the community more broadly, and they may just never get a diagnosis. So, and then when we think moving forward about hopefully treatments for these diseases, that 5-year delay is just something that we need to address, and we need to be able to close that gap so that we can help people earlier.
And what does the research say about that early, you know, intervention pathway? You know, if caught early, you know, what are the sorts of things that are considered, you know, best practice? Or, you know, I know that every dementia is different, because that's a big umbrella term, and you know, it might be very, very different if it's a sort of vascular one versus you know, other ones. What was the one that you mentioned?
Lewy bodies or Alzheimer's or
that'd all be a bit different, but early intervention nonetheless. Are there is there an optimistic side to this in terms of what can be done? You know, because it can sometimes feel like these things are, you know, kind of beyond, you know, beyond supports, you know, that it's a disease and therefore you can't kind of, you know, recover, etc. We've all seen, you know, what it looks like at its worst. Most of us don't really understand what it looks like at its best, and hence why 5-year delay is considerable period of time. And it's obviously very difficult to get a loved one into a doctor to look at those things.
Yeah. No, that's a great question. So I think, you know, even if you had have asked this 5 years ago, many clinicians probably would have said, I don't think that there's any point doing rehabilitation. This is a progressive disease. Why, what are we really going to do? We're just, rearranging the chairs on the deck of the Titanic. What are we actually doing here? But there's actually a lot of research now saying that that's maybe not the case, that people living with dementia can benefit from interventions. So, for example, in the sort of more language presentations, there's been a lot of work now looking to see if you can help people maintain their ability to communicate through a variety of different interventions, mostly led by speech pathologists, which have shown to be very effective. And those interventions have been shown to be maintained for, 3, 6, 12-month periods. So there's a lot more research looking at specifically targeting skills and cognitive abilities that may be affected, and thinking about how we can intervene so that we can slow the progression in people. There's also
what are those things? What would the speech pathologist do?
What do they do?
Yeah.
So for people who are having challenges in terms of expressing themselves, where they might be have more like the speech might be stuttered or labored or effortful, or they get tripped up on words, they do what's called script training, where basically if you look at a particular area of interest, I don't know, maybe you're obsessed with rugby league, you could learn some sort of sentences and scripts around rugby league so that you can produce that more automatically. And then when you're in a social situation, maybe you're going to your community group, you're at church or whatever it is that you're doing, when someone says, oh, how are you going? Then you would have this script ready in terms of rugby league so that you could have a conversation with someone. And you can learn various scripts so that they become more automatic and more well practiced to help people communicate more easily without that sort of stuttering and challenges in terms of expression.
In some way, it reduces the anxiety and increases the possibility of social participation, because if the opportunity is there, you might still be withdrawing versus being able to engage a bit more if you already have a script as a starter. As a starting point, which then maybe, lubricates the conversation a bit and allows you to get away with more more of those opportunities. Wow.
Yeah.
That's really clever. I didn't think about that whatsoever. I'm like, what a speech pathologist is. Like, wow, that makes so much sense. Very simple intervention, but amazing.
Exactly. And the other sort of classic intervention is when people are having difficulty thinking of the names of things. So you, I'm sure, have experienced that sort of tip of the tongue phenomenon where you're like, I know it, but I just can't think of the word. So people with a form of frontotemporal dementia called semantic dementia will experience that for many, many different items and objects. So they just slowly lose vocabulary over time. And so what you can do are very simple interventions, which are basically like word picture matching, where you'll have like a photo of a kettle and they'll have to come up with the word kettle, and a photo of a toaster and they have to come up with the word toaster. And again, it's practicing, many, many trials, but that will help them get over that sort of feeling of like, I know the word, but I can't find it. So it's sort of trying to find compensatory strategies to deal with the specific issues that the person is having. And again, they've been shown to be quite effective. And also, I guess, very importantly, people living with dementia find it very satisfying. So, they are obviously having these challenges in everyday life, but they're very happy to do these sort of training exercises because they can see the real benefits in terms of being able to maintain their function. And then the ability to communicate then, like you said, improves their quality of life. They can participate more fully. They're more confident in social situations. So those sorts of things are starting to gather a lot more evidence.
It seems like it's almost like a rehab, right? You're flexing the cognitive muscle over and over again by doing recognition of picture and the word, having to put cognitive load to find the word. That can be quite enjoyable from a mastery perspective, and even more importantly from a functional perspective, when you can actually see your cognitive capacity improve. That's reinforcing and it builds confidence. And once again, you probably have better recall when you are confident. And around and around we go. And something like that, wow, I can imagine there would be some pretty easy apps that could be developed to increase the difficulty level of going from a kettle and a cup and a chair through to more obscure objects.
Exactly.
Like, I don't know, I can't even think of one. There's the tip of the tongue phenomenon, right? But something that's a lot more challenging to recall because it's not part of a regular day life.
Exactly. Yeah. So a lot of the programs have actually come from stroke, so from classic rehab settings. And like I said, people just thought there was no point in trying this in dementia. It wouldn't be successful. People wouldn't be able to do it. They'd, be confused. But actually, quite the converse. So people with dementia have found it really beneficial. It has been effective. And exactly like you said, now there's a lot of collaboration with development to be able to roll this out more broadly to people.
Well, it's maybe the evidence is starting to lean in that direction. I know that and this is probably not a good place to do your research by any stretch of the imagination, but I know when I read, I think it's called The Brain That Changes Itself, Norman Doidge, I think it is the author, talking about the importance of those first 3 months of rehab, how important. But, inadvertently, it maybe sends a message of 3 months is where you do the work. And after that, you don't have recovery when in actual fact, 3 months might be exceptionally important, but ongoing rehab period, just like ongoing training for an athlete is necessary. Even if you're a peak performance, you just keep at it to maintain, and there are there's still progress in that. And I imagine particularly for dementia, because there isn't a stroke or something involved. It's in actual fact sometimes the flexing of that muscle or cognitive load, and interestingly might be social cognitions rather than just executive functioning. Going out and stimulating that makes a lot of sense. I know that even from a nerve perspective, the value of massage in areas that might feel numb or whatever it might be, just touching those areas as much as you can with it, tapping, massaging, pressure, etc. All of those things are important. Not that we necessarily know the full mechanism as to why it's important, but we definitely know it is important. And to stretch your mind to have that cognitive load sounds like it's really important. And from a social perspective as well, social load, if we can call it that. Not sure if that's reasonable.
No, I mean, I think that's a really good point. And I think this is really where my research certainly, but also I think research more broadly is moving to in the dementia space. So obviously there's a huge amount of work being done to understand the mechanisms, why someone gets dementia, how can we treat it, what drugs would work. All of that basic science is absolutely fundamental to making progress. But we also know that, in Australia at the moment, there's nearly 500,000 people living with dementia. And if there isn't an intervention by 2050, it'll be, 3 times the number. So there is a really increasing number of people living with dementia. And on average, a person with dementia from when they first get symptoms will survive for around 11 years. So there's this huge opportunity for intervention in that period. And I think that's where there's a lot of research to be done in terms of how can we best support people, how can we maximize quality of life, how can we help people live in the community for longer. And also we know that it has an impact not just on the person living with dementia, but their families as well. So how can we support family members who are caring for people with dementia, reduce their burden and really, support people during this challenging period. And, I just think that there's a huge amount of opportunity there and a huge number of people who are affected. And that's where the research really needs to focus now.
But being in that space of research and having looked at, for example, the social factors, what would you like to see as being some of the interventions, or where do you feel there's merit in exploring further, doing more research, and where what's your hunch in terms of, obviously we can definitely see that, the rehab side of, cognitive load and, mastery and, whether it's scripting of a conversation, they're all kind of, useful. What do you think, is an additional piece, and obviously there are many, but from that social side, what do you think is a good place to explore and start looking at?
Yeah, that's a really good question. I mean, we've been doing a lot of focus groups now with carers of people with dementia and people with dementia themselves, and trying to hear from them in terms of what their experience is and where they need help. And I think one of the things that keeps coming out over and over again is that support after diagnosis. So, people really say to us, even once I got the diagnosis, then I thought that people would give me all of this information, and we never really received that. And they just feel like they get sent home without any support or network around them. And I think that's really, something that we need to change. We need to be able to be providing that support, in that post-diagnostic process, and really integrating the person with dementia and their family more broadly. I think part of it is actually raising awareness in the general public as well. So there's currently a dementia action plan that's being put together by the state and federal government for the next 10 years in terms of what to focus on for people with dementia and how we can improve their quality of life. And one of the aspects of that is looking at inclusive communities and thinking about how, as a community, we can change to really support people with dementia to live independently and support their families. And I think from the social side of things, it is really going to be a community approach that needs to be taken here. In some ways, while there are efforts to take that rehabilitation approach in the field of social cognition, so for example, training people in terms of how they might detect someone's facial expression, detect how they're feeling, and that's something that we could look at in more detail. I think more broadly, this is a challenge for us as a society. And like what you were saying with some of those documentary programs in terms of multi-generational interactions. So, having people more embedded in the community rather than in their own residential care facility with all the dementia, people living with dementia who are isolated. I think that is really where there's a lot of progress to be made. And certainly internationally, in the Netherlands, for example, they're looking at changing how residential care facilities are set up. So they are more in sort of group home settings where you'll have 5 or 6 people living together. They'll be responsible still for, cooking food and doing groceries and planning the activities for the day, moving away from that sort of more institutionalized care, I guess, where people have to follow a strict regime and their food's provided for them and they're given structured activities. I think all of those, more innovative ways of providing care, really is going to help. And I think as a society, thinking about how we can be more inclusive, how we can enable people to be more integrated, is going to be really, really beneficial from that social participation perspective.
It seems quite a challenge looking at it from a cultural perspective. The cultural shift is potentially a challenging one in that it feels like in some sense we live in quite an individualistic society, and some of the intervention here is integrating a more social based, community based, connection based, where these, rehab is occurring just because there is engagement, rather than saying, here's your program, we'll set up an iPad for you and you do A, B, and C, versus no, in actual fact, you have a role to play, to continue to play in society.
Yeah.
And there's routine, and, you've got worthwhile things to attend to. There is a there's a community understanding of some of your challenges, so that you're not judged, and you can continue to participate and provide value to that community, and in an enriching way, and it's a much more robust way of supporting the vulnerable, or continuing to value the vulnerable, rather than you've got a productive life and then you age, and then all of a sudden we're caring for you, versus no, you continue to provide great value.
Yeah. No, I think you said that so nicely, and that is such a great message. Again, from our interviews with carers and people living with dementia, they really have said, the day I got that diagnosis, the message was, go and sort out your estate, go and sort out your will, quit your job, because, that's really the end of you in terms of what you've got to offer. And I just don't think that that's the right message. Again, we can think about other clinical syndromes where the community approach has shifted. And I think that we can really apply that in dementia as well. And absolutely, as you said, people, even with the diagnosis of dementia, are still really valuable members of society. They've got a role to play. They've got things to contribute, and, trying to embrace that. And I think focusing on quality of life. So, how can we maximize people's quality of life? And I think absolutely part of that is engaging and having that social engagement.
Are there any programs in the research that you can point to that have done this well, across the world, where it's either been applied in a particular way, quite structurally, or research has looked at how communities have naturally gone out and supported, folk that are, having these types of challenges? Anything that you can point to that we can learn from?
So one of the areas that I'm really particularly interested in is cross-cultural research and sort of cultural differences. And I think you alluded to that a little bit when you were talking about, these multi-generational approaches and the sort of individualistic versus perhaps a more collectivistic approach. I think there is a lot to be learnt in terms of thinking about how other cultures approach aging, really. And as part of that, these diseases of aging like dementia, it's particularly relevant in the Australian context, where we do know we have so many people from different cultural backgrounds. So I think it's, 1 in 5 people were born overseas, 1 in 3 people, second generation. So there's so many different experiences and knowledge. And I think that's certainly an area that we need to tap into more in terms of how different cultures focus on these changes in dementia and potentially taking information. So one of the things that we've been doing is looking more closely at people who come from different cultural backgrounds and look at, whether that changes the actual presentation of dementia. Are the symptoms different? Is their progression different? Do they have a different trajectory? And seeing what that can tell us in terms of how we can potentially manage this better.
Are there any differences with, among or between cultures?
Yeah, well, it's very preliminary research because we were only able to compare people from non-English speaking backgrounds, people from English speaking backgrounds, but born outside of Australia, and people who were born in Australia. But we did start to see some subtle differences. So, one of the things that we found was that in people from non English speaking backgrounds, they tended to have less severe cognitive impairment when we looked at the sort of neuropsychological performance. And we think one of the reasons for that is because actually all of that group were bilingual. So we think that they had sort of greater cognitive reserve. So when the dementia started progressing, they were able to manage that a lot better. So there's certainly evidence that being bilingual is very positive in terms of slowing that rate of progression. We also saw some differences in terms of the actual symptoms. So the people who were Australian born tended to have more apathy and more changes in sort of motivation, whereas the people from non-English speaking backgrounds tended to have more changes in eating behaviour. We don't really know exactly why that's the case, but we have some hypotheses in terms of why these things might present differently. So if you
behavior, like eating more, eating less,
eating more sugar
more
tends to
sugar.
be one of the symptoms of frontotemporal dementia. So like a tendency to prefer sweet foods or high carb foods. And that seemed to be seen more commonly in these people from non-English speaking backgrounds. So yeah, we don't actually know what's going on there in terms of these different symptoms yet, but we have some hypotheses in terms of, I guess, changes in social norms. So if you think, for example, a person from Japan in terms of what's socially appropriate, that might be quite different to someone from Argentina, for example. So in Argentina, you might be very forward. You might kiss people to say hello. People might be more gregarious, whereas people from Japan might be more reserved. Something really inappropriate in Japan might be wearing shoes into someone's house, whereas that isn't, seen as socially inappropriate in many other countries. And if we think about these changes that are happening in your brain in terms of social cognition, maybe that can influence how it manifests, so that the actual symptoms that present will be a combination of the changes of what's happening in your brain, but also a product of your culture. And so when we're thinking about how we diagnose these different syndromes, particularly in terms of social cognition changes, we think that there might be differences in terms of, what are the key defining features or what are the most obvious features. And so we need to think about that when we're doing international research, to make sure that we're comparing apples with apples and not apples with oranges. So again, I think that there's a lot of potential there in terms of examining some of these cultural differences and how, our social context, our cultural background, whether we're bilingual, all of these things will also influence the actual presentation of dementia.
And is there a hypothesis around why sort of reaching for more sweets, more carbs might be occurring?
There's two different hypotheses. One is simply around disinhibition. So possibly, the parts of the brain that are affected in frontotemporal dementia is the sort of frontal lobes of the brain. And often we think of that as our sort of brake. So the thing that sort of stops us from doing things. If you remove the brake, then you might just go down that route of having a preference for more sweet foods or high carb foods. So that is one hypothesis. There are also there is another hypothesis that it's potentially around changes in metabolism, and that there's more autonomic changes, or I guess changes throughout the body that are also occurring in these dementia syndromes that might be related to the disease process. And that one of the reasons for that is because we see this very high increase in calories, but we don't see the same amount of change in weight as we would expect. And so that has led some people to hypothesize that there might be metabolic changes that are happening in these people, and that actually their craving for high sweet, high carb food might be actually part of the disease process, in terms of changing how our brain and how our body's metabolizing things. So again, I guess that is research that's really currently underway. There's a lot of people doing work on these sort of metabolic changes, to investigate whether there is more of a disease-based reason for why this preference in food occurs, or whether it's simply another manifestation of that sort of disinhibited behavior.
So fascinating how many possible areas can be explored in trying to understand how, this umbrella term of dementia shows up, and obviously protective factors like, whether it's bilingual or education level, engagement, cognitively and socially. I've always thought, certainly my parents' old age, I've always thought, the importance of keeping them engaged and active and giving them jobs. I used to look after most of my garden, but now I've, in many ways passed it over to my dad, and that's his job. And he doesn't realize that. Well, I mean, I do like to have a nice garden, but part of it is I get a lot of pleasure in seeing my father active, because, as a retired, older person, there's only so much that, he's got to do around the house, and to give him another project or something to do. Plus it's meaningful, he does like, serving others and acts of service, very European thing, I think, as well. I think it does give him a sense of enjoyment. And so whenever something happens, I always find him, I'm like, oh, Dad, the lawn looks amazing. Thanks so much. And, but I think it's protective. I think, it's engaging. It gives him a purpose, and, and the like. Not that he doesn't have those things, but it adds to it. And I've always thought I've got to keep my parents engaged, because, as they age, they also lose a lot of social connection, whether it's through, death or, mobility issues from themselves or, their friends. It starts to dwindle. So their opportunity for social engagement and those sorts of things just really dramatically decline.
Yeah, I mean, again, there's a lot of research looking at people's social networks changing, and even, putting GPSs on people and seeing how far they travel. And you just see this, gradual decline in terms of the space that people occupy, the number of connections they make, the number of people they see. But yeah, it sounds like your parents are very lucky, and I'm sure your garden is very lucky as well, by the sounds of it. It's a good strategy.
Well, at least that's the story I tell myself, so that, I can get them to do everything that I don't want to do.
Yeah.
It's for you, Mum and Dad. This is just love.
Yeah, but I think coming back to your point in terms of, there is so much, there absolutely is. And that is why I love this area of research, because, while people often think dementia is very depressing, and they say, why would you research that? It's horrible. It's actually just so, firstly, fascinating to understand the complexities of the brain, understand all of these things that can happen to people. And it really tells us a lot, I think, about, how the brains are organized and what's important and what influences our health and so forth. But also I just get so much, we're very lucky. We have a lot of participants and families who are involved in our research, and just learn so much from working with them. And there's so much more research that can be done. I really feel like, dementia is very, very early in terms of what we have to understand. And there's a lot of progress still that needs to be made, but it also means there's lots of opportunities for really fascinating research, and particularly at these intersections, I think, between, neuropsychology and sociology and, cultural differences. And, we haven't really spoken about it, but, how dementia might fit within like law and the legal system and those sorts of things. So there's a lot of really interesting interactions and potential research that can be done, around neuroscience, thinking about, how we can study the brain better, how we can track these changes over time, how can we actually measure what's happening in the brain. It's just such a fascinating area. I feel really grateful to be working in this area.
And the real, I think, value in all of that is then using that research to inform social policy, so that we understand how can we do these things, maybe not so much on an individualistic level, and maybe some of it is certainly individualistic, but certainly as a collective, and being able to understand and maybe shift a little bit. Not that we don't understand it, but I think we can highlight it some more, that a better way to age with dignity and with value, that can be celebrated, because we're all leaning in that direction. You and I are not far from one day just being of age that naturally things are decaying, and whether it's our heart that's decaying or our liver that's decaying, or a brain that's starting to decay, I think we deserve as human beings to be treated with a lot of compassion and nurturing care, and also that we are still contributing members of society in so many ways. Obviously we're more likely that we're not doing paid employment at that time, but that's certainly not the only contributing factor. And I think the old and wise is something to be embraced, to learn from, and also to be nurtured, because it also tells us a lot about who we are as a society, how we look after our most vulnerable, and yes, the young ones, but also the older ones, that both can teach us just as much. So I really appreciate your work and appreciate your passion, because this is, I think, an optimistic conversation. Yes, disease is always difficult to talk about, but there's a lot of optimism here. There's a lot of opportunity to slow the progression of the disease, or in some sense, probably lack of a better word, but reverse some of those effects, that in the right environment, with rehab and social integration and meaning and value, that we might see people in a very bleak situation, and with the right intervention, optimism and improvements sort of arise. Where can people find out more? Where can they read about this more, continue the conversation, find out about your work? Where can we continue this beyond this podcast?
Absolutely. Yes. Thank you so much for saying that. And I totally agree. I think there'll be so much happening in the future. So it should certainly be hopeful rather than hopeless. In terms of more information, so our group is called Frontier, the Frontotemporal Dementia Research Group at the Brain and Mind Centre at the University of Sydney. If anyone wants any information about frontotemporal dementia, you can go there. The website is ftdrg.org or frontier.org. And if you're interested in more about neuropsychology, I also have a neuropsychology clinic here at the Brain and Mind Centre. It's called the Sydney Neuropsychology Clinic. So if anyone wants to find out more information about neuropsychology assessments, or you're interested in getting one, you can go there. In terms of dementia more broadly, Dementia Australia has a fantastic website full of resources. So yes, you can just Google Dementia Australia, and they have huge amounts of resources there. So I would highly recommend there to check out more. And I'm also on Twitter, so you feel free to follow me there and chat further. But yeah, please do get in touch.
Yeah, no, I appreciate you so much, and I appreciate your work. It's lovely to have pioneers, to continue pushing these important topics forward, and people who are passionate. So, I wish you all the best, and hope that our research as scientist practitioners can be used for social policy and for individual families too, to say there's actually a lot that can be done, and we can still live meaningful way as well. There can be sadness at times, but there's still more than just that. So, love your work, and yeah, I can't thank you enough.
Thanks so much for having me. It's been great to chat.
If you enjoyed this podcast, please support it by going to iTunes and putting a review, subscribe, share it via social media, and tell others about it. Start a conversation. It's listeners like you that make this able and possible, and why we bring in these guests to go out and share their knowledge and resources. And just lastly, if you are a psychologist and you want to go out and be part of a bigger team, develop your experience and get into some exciting work, come to strategicpsychology.com.au/careers and reach out. I'd love to hear from you.